I'm going to very briefly talk about GLP1 receptor agonist. Dr. Ponde gave us a beautiful lecture on the SGLT2, and I think the SGLT2 has been much more frequently used, at least amongst cardiologists, than GLP1, partly because it was an injectable form that was available till the recent oral forms that get available. So when we talk of incretin-based options, you have the DPP-4, which has been extremely well, again, discussed just a few minutes ago, which are the incretin enhancers. And then we have the GLP receptor agonists, which are the incretin mimetics, on which I'm going to talk. We already know about how GLP-1 works through the brain, through the GI tract, through the liver, and through the pancreas. So there are multiple modes of action through which GLP-1 receptor agonists work. So they produce increased nitriases, they're cardioprotective, beneficial effects on coagulation, beneficial effects on inflammation, very important again, reduction of blood pressure, body weight, and of course their effect on glucose control as well. So they reduce inflammation, they increase spark stability, and they prevent progression of atherosclerotic plaque. So it's very important to realize that these are actually anti-atherosclerotic drugs. So clearly there is a very important role of these drugs in the management of cardiovascular disease. There have been a large number of trials which have taken place over a long period of time and which have brought, according to me, the GLP-1 agonist right at the same level as the SGLT2 inhibitors. If we look at the liraglutide trial and the multiple lead trials that were done, you can clearly see one effect, that is the reduction of HbA1c, because of course primarily they were used for treatment of diabetes, and of course they need to reduce the A1c, which they do quite significantly. If we look at body weight, which is another very interesting aspect of the GLP agonist, is that they have a very superior body weight reduction. And you can see from here a very significant reduction of body weight. So reduction of A1c, reduction of body weight, and again, as I mentioned, reduction of systolic blood pressure. So even these simple things of reduction of body weight and systolic blood pressure can have a very profound effect on cardiovascular disease. Add to that, the dark blue is the liraglutide, and you can see a reduction of total cholesterol, a reduction, again small but definite reduction of LDL cholesterol, and quite significant reduction of triglycerides. So again, you can see the beneficial effects of lipids on future cardiovascular events. They also produce a reduction of BNP and a reduction of HCRP. And I think we all know from statin trials how important HCRP is, and raised HCRP along with raised HDL, which raised LDL, can produce significant cardiovascular disease, and the reduction of CRP is a further contribution of SGLT2. And of course, they improve the indicators of plaque stability, looking at the inflammatory responses, the oxidative stress, and collagen content. And you can again see that these drugs have a positive benefit. If you look at more anatomical changes, you can look at the carotid intimal media difference, and you can see there's a significant period over time where the carotid intima thickness becomes better. So clearly there is a practical benefit in terms of the vascular benefit of these drugs. We all have seen about the LEADERS trial, and looking at the overall maze of cardiovascular death, non-fatal MI and non-fatal stroke, it's a 13% reduction in terms of the benefit of liraglutide over placebo. So the aspects I showed you about reduction of weight, systolic blood pressure, effects on cholesterol, and various inflammatory markers, and this can be then now seen in a big trial on the clinical benefits. Even if you look at some of the subgroup analysis, you can see that there's a definite reduction in the incidence of MIs. So MIs were systematically collected and looked at, and you can see that the incidence of all MIs was significantly lower. So we are not talking about heart failure group of patients, which of course we know a lot with SGLT2 inhibitors, but we are now talking of the cardiovascular part, the coronary artery disease, and the stroke and myocardial infarction. Liraglutide also has some effect on the renal outcome. So it's not that there is no effect on the renals. If you can see outcome of microalbuminuria and doubling of serum creatinine, you can see a composite outcome reduction of 22%, and the new onset persistent microalbuminuria reduction by 26%. So though so much has been talked about SG2, LT2 and renal dysfunction, improvement in renal function is also seen with GLP-1. Then we move on to this semaglutide, which is their new drugs which have been more extensively studied now. A large number of SUSTAIN and PIONEER trials looking at cardiovascular events. Earlier it was injectable, now we have oral. Again, if we look at the benefit in terms of HbA1c, again, of course, dramatic benefit of about 1.5% in the HbA1c throughout many of these PIONEER trials that have taken place. Again, if you look at weight reduction, similarly significant weight reductions up to 5 kilograms. And I think many of you know about the use of injectable semaglutide for treatment of obesity. But clearly the benefit in terms of blood pressure reduction, A1C reduction. And then when you look at the MAZE at various patients with established CVD with placebo versus semaglutide, and you look at the SUSTAIN and the PIONEER trials, you can see a consistent benefit in terms of endpoints for these cardiovascular endpoints. So clearly, like the liraglutide leaders trial, the SUSTAIN and PIONEER trials show cardiovascular benefits. And if you look at different endpoints of these, you can MAZE, again, benefit in terms of GLP1, CV death, benefit in terms of non-fatal MI and non-fatal stroke. Please don't forget stroke, because many times as cardiologists, we talk a lot about coronary artery disease. We don't talk much about peripheral disease and stroke. But any drug which benefits cardiovascular and atherosclerosis will also have a very significant benefit in terms of stroke and peripheral vascular disease. So please don't forget other vascular systems of the body will includingly get the benefit. And here you can see the cumulative incidence of stroke over time, again, a significant reduction of stroke. So not only is it a cardiac drug, I think it's a very important neurological drug as well. And again, if you look at a combined meta-analysis of the GLP-1 RAs in terms of the risk of MACE and looking at all these various trials, and you can see again a significant benefit in all the trials for the cardiovascular endpoint benefit. This has been shown earlier. As you can see now, we have an option of choosing SGLT2 or GLP-1 along with metformin. And clearly, there's no doubt now that people will continue to, of course, use metformin in patients who are on or either not on metformin. But the next drug of choice today, especially in those with heart failure or with cardiovascular disease, will be either an SGLT2 or a GLP-1. Now, often the question is, which of these two drugs would one choose as the first-line drug? And this is the nice talk which has been talked about, the pumps, pipes, and the filters, the pump being the left ventricle, the pipes being the coronary arteries and the rest of the vascular system of the body, and the filter being the kidney. So if you have a problem predominantly related to the pump, that means LV dysfunction, heart failure, low ejection fraction, then clearly SGLT2 is much more evidence of benefit for these problems. If on the other hand, you look at the pipes, the coronary arteries, and looking at the coronary tree or the peripheral vascular tree or the carotid tree, you will see that the benefit is much more significant with GLP-1 receptor agonists. So I think that we can differentiate between whether we should use SGLT2 or whether we should use GLP-1. And again, there is no reason why we can't combine the two together. I'm not sure if there are too many trials using combination of these two, but certainly many of the patients are on both these drugs, and I presume that they will get additive benefits from combining these drugs. Now, again, we keep talking of heart failure and SGLT2, but if you look at ASCVD as a whole, you'll see that there's a large number of patients who have coronary artery disease, large number of patients with carotid disease, and again, a significant with peripheral artery. We do not deny the fact that heart failure is common nowadays and gradually increasing as well, but do not forget that heart failure in a large number of patients is actually because of coronary artery disease. So clearly treating the ASCVD at a very early stage, especially in a country where diabetes is so common and seen at such an earlier age, the early use of GLP-1 agonist will be of great benefit. A point looking at here is the EMPA-REG trial and looking at the region and looking at the discordance between the direction. If you look at the 3-point MACE compared with CV death, compared with non-fatal MI and non-fatal stroke, you can see that the curve is different. As if you look at the GLP-1 agonist, you can see that there's a benefit for all the parameters, non-fatal MI, non-fatal stroke, CV death, and the 3-point MACE. So clearly the benefit is over the board rather than a discordant benefit as we saw. We know that there are some side effects, particularly related to GI, nausea, etc. They can be self-limiting. You can start with a lower dose and up-titrate slowly. You can get more information about this from a diabetologist who are far more experienced than I do in terms of the GLP-1 agonist. So clearly, when we talk of GLP-1 agonist, I think the use is underused. And I think there are a number of reasons. The knowledge is less. There's much more talk about SGLT2 inhibitors rather than GLP-1. They're more diabetic-oriented drugs rather than towards the cardiovascular group of doctors. Again, because they were injectable, the cardiologists were less prone to using them. But now we have oral drugs. So clearly, our knowledge has increased about GLP-1. Nausea and certain side effects can be controlled, and the diabetologists have various ways in which they can do that. So now cardiologists will have to think of these drugs as beyond diabetic drugs and as cardiovascular drugs. And of course, diabetologists have already understood that reducing blood sugar is only one very small aspect of treatment of diabetes, and preventing cardiovascular death, stroke, myocardial infarction is of great significance. So I think we have covered SGLT2 beautifully by Dr. Ponde, and with this use of GLP1. I think cardiologists should use both these drugs for the great benefit of patients for reducing cardiovascular disease. Thank you very much indeed.